I want to welcome you to the 8th Annual World CME and Disparities Impacting Global and Local Populations Conference. This is being jointly sponsored by Health First, Mednova, SUNY Downstate, my alma mater, and Howard University, College of Pharmacy of Continuing Professional Education. I'm Dr. Karen Costley, AVP Medical Director at Health First, and it's a pleasure to have you all here. Happy to see you. Little background, over the past 8 years, the World Health CME has offered a chance for dedicated healthcare professionals and medical students, like some of you here, to commit to the work of advancing health equity, both locally and globally. In a city as diverse as New York, we are often reminded that global health is not just confined to distant countries. It lives in the communities we serve. New York is home to individuals from every corner of the globe, many of whom face barriers to accessing care, whether due to language, socioeconomic status, immigration status, ever present, or cultural differences. Vulnerable populations often bear the greatest burden of disease and often lack access to resources and support to the services they need. As healthcare professionals, we're uniquely positioned to be a part of the solution. This means delivering care that's not only clinically excellent, but also equitable and culturally responsive, and to make sure that we speak up when we see inequities in the system. We're honored to be joined today by leaders in the global health field, and we look forward to their engaging presentations and discussions. On behalf of Health First, we thank you again for being here, and I'd now like to introduce my co-course director, Dr. Henry Paul, to say a quick welcome and to share more.
Good morning. I'm Dr. Henry Paul. I'm a nephrologist here at SUNY Downstate and also a co-director of this event today. I'd like to take this opportunity to thank our partners, Howard University, Health First, SUNY Downstate, for being very loyal and sticking with us for 8 years during this conference. Medinova, I'm the president of Medinova. We're a nonprofit organization working mostly in Haiti. We do medical missions. We've been to the Bahamas, the Dominican Republic, most recently Jamaica. And we also have a clinic that we are managing and running on the northeastern part of Haiti. So our mission is to provide quality healthcare to the underserved in that country. And we are always recruiting for physicians, nurses to accompany us on our events. So with that said, I'd like to introduce one of our partners, a very dear friend, Dr. McDonald Pinkett, to come and say a few words.
Good morning, everyone, and welcome to our conference today. It is certainly lovely to see you all, and I appreciate being in Brooklyn. A little different, but we're glad to be here. I'm Shelley McDonald Pinkett, faculty in the Department of Medicine at Howard University College of Medicine. I don't think I need to tell you who Howard is, so I won't, but just know that we are always interested in global health, the interest of our nation, and the interest of all of those in the communities that we serve. Today we have a very special group of people who will be presenting their information and global experts, and we're so pleased to be a part of that conference material. My job now is to introduce to you Dr. Moro Salafu. And Dr. Salafu, would you please come forward?
Good morning to all of you. Let's do it the Brooklyn way. Good morning. Very nice. First of all, I'd like to acknowledge Dr. Cosley. You said you're an alumnus of the College of Medicine at Downstate. Wow, that's that's very nice. So welcome home. Yeah, and congratulations on your new position. I also want to acknowledge the partners, Health First and Medinova, Howard University, for this outstanding long-term program that they've been putting together for many, many years on global health, addressing so many topics, and also providing real-time care to patients abroad in Haiti and other countries. And I was lucky to be part of one of the medical missions in Cap Haitian. It was just remarkable what it meant to be part of that process. People don't just have the health care, and they're just struggling. Medical students, it's just amazing what you can do just with your presence, even without doing anything. Just the motivation of someone looking at you and say, wow, I can be something, was really something. So I was very, very impressed. I'd like to bring greetings from the College of Medicine. Again, yesterday was a big day at Downstate. The governor approved $1.1 billion to renovate and build new systems at the University Hospital at Downstate. So we're looking forward to, when you talk about global health, I think when you walk on Clarkson Avenue, you see how global this university is. Right? You see everybody from various walks of life and basically from a lot of countries around us. As a matter of fact, a block from here is called Little Caribbean. That is the community. It's called Little Caribbean. So to be able to, provide funding to that level, to make the hospital, to modernize it, and to revitalize it for the service of this community, and to support the academic mission of the university is really, really something that the community really deserves, needed, and the governor just delivered so well. And so that was really, really very good news for the hospital and for our president, the dean, and everybody else. So I'd like to welcome you on behalf of SUNY Downstate to this conference. It's a very important conference addressing various kinds of topics. Some of you have come from far, you've traveled, and I hope that you'll enjoy the conference and be able to get home safely as well. There are some few, announcements I want to make, some housekeeping stuff I want to make. For those of you online, please utilize the chat feature on the Zoom to post your questions for the panelists anytime during the conference. We would like the panelists to come at the end of each of the sessions, and then we'll take questions. We'll hold the questions until that panel is finished. They will all come, and then you can ask your questions. And for those of you in person, there was supposed to be a booklet, but there's some issue. But you get a booklet very soon. The agenda is in the booklet when you get it. Just follow the agenda, and then you'll be able to see who's speaking and who's not. But you would get that anyway from the moderators who will be introducing each speaker quite well. There are going to be scheduled breaks. We have 4 sessions. So each of them takes about 2.5 hours. Then there will be the panel, question and answers, then a break. They will come back after the 4 sessions, then we close. Okay, now for CME, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the SUNY Downstate Health Sciences University and Health First. So the CME is actually coming from SUNY Downstate. SUNY Downstate designates this educational activity for a maximum of 6.7 AMA Category 1 credits, so CME, each one of them, each hour is 1 credit. At the conclusion of the conference, you will have a link to do an evaluation, which is usual. After the evaluation, you're going to get your CME credits. Make sure that you have checked at the registration desk outside the foyer if you have not done so, to make sure that your registration is completed, because we're going to be looking at the registrations and matching that with your CME requests, right? For pharmacy credits, we are pleased to offer CE credits for pharmacists again this year. So if you're a pharmacist, you're going to get credits. Howard University College of Pharmacy is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. The program meets ACPE criteria for pharmacists. The education credits will be awarded through the CPE monitor within 3 to 4 weeks of the seminar. So expect to get that within a month after this event. Each of the educational activity will be shared electronically after the conference has concluded, and the deadline to claim your CE is August 1st. So please make sure that by August 1st, we have your request for CME or CE credits. All right, so that is that from me. So now I would like to invite back to the podium Dr. McDonald Pinkett to introduce the first panel. Speakers, please be as brief as possible. We don't want to overrun the time. The questions and answer session, please ask your questions succinctly so that we can get, like on-target answers to the questions, and then so that we can run the sessions more effectively. So Dr. McDonald Pinkett, podium's yours.
All right. Well, good morning again. We're pleased to get our first and the most exciting session started. I will introduce to you our speakers. And I won't read their bios. The booklets are being handed out to you now. And so you can certainly take a moment to do that. And I would advise all the students to certainly read the bios of each of our speakers. Our first speaker in this session is Dr. Torian Easterlin, the Senior Vice President for Population and Community Health and the Chief Strategic and Innovation Officer at One Brooklyn Health. Dr. Easterlin's topic is Advancing Justice, Historical Roots, and Future Solutions for Health Equity. Following Dr. Easterlin, Dr. Marverine Beverly will speak to us. She is a patient engagement and cultural competence specialist, and her topic is Patient Engagement and Cultural Competence, the Roadmap to Achieve Health Equity. And though those two speakers are certainly great, the next two are near and dear to my heart, and so I have to give a special welcome to them and a special introduction to them. They have been very supportive of each other, of women at Howard, of women in the Black community, and women globally. The first is Karen Roberts Turner. She's a Senior Associate General Counsel for Health Sciences and Adjunct Assistant Professor of Ethics at Howard University. Karen's topic is, Attorney Karen's topic is ethical decision-making in diverse populations. And just on a tiny, tiny personal note, I know, Dr. Salafu, you said to be brief, but I have a hard time following directions. She is just the kindest person. She makes sure that you're well taken care of in her field. I first met Karen. She was sitting at a table leading a group of very, very distinguished and accomplished attorneys, physicians at Howard University. But I was so proud to know that she was there and then to get to know her after that because of the way that she was able to manage that group and how she's managed her career. So she's just a wonderful person. After that, we have Ms. Brenda D. McDonald, RN, and all the other letters after her name. She is the Clinical Risk Advisor, National Healthcare Practice at AON, and a forever Howard University employee, ma'am, just so that you know that. The title of her talk is The Cost of Getting It Wrong. And I'll tell you, the first time I came to Brooklyn and to meet with Noah New York and Henry Paul, it was Miss Brenda Douglas McDonald who accompanied me. She assisted Howard in getting the affiliation with Noah New York, now Medinova. And she is a stalwart. Now, Karen, she'll pick you up and rub you and make sure you're okay. Brenda's gonna bowl you over and then check back a little bit later and make sure everything's okay. But just another support for women, professional women, always supportive of Howard University, supportive of our students, and I'm so pleased that you too have joined us here today. With that, you told me to be brief, so I spent all my time on these two. Dr. Easterlin.
Good morning, everyone. What an honor to be here. Congratulations to all of the lead faculty members and the planning committee members for this occasion. I just want to make sure that I know what I'm doing. Great. Okay. I have my slides in front of me. Once again, as you've already heard from Dr. McDonald-Pinkett, my name is Torian Easterling. I'm a family physician. I formerly served at the New York City Health Department, and so you'll see some familiar slides and familiar information which I presented before, but I will not stand before you long. Sometimes I don't follow directions, but I'm going to do so this morning because we do have a really august group that I have a chance to be a part of on this panel, and I want to make sure that they have their due time as well. One of the things that I think has been really, really important for some of the work that I've been doing is really making sure that we're naming some of those issues that we're talking about and really being bold in a way that we're not just sort of passing by it and making sure that we give language to the issues and the challenges. And given that we do have folks who are online, you'll see in some of the earlier slides, there are a lot of contextual things that I'm talking about here in New York City. But I do think that these are cross-cutting issues that we're facing not only in New York City, but around the world. And as you've heard from Dr. Salafu, an example of how community organizing, both from an academic standpoint, from policy standpoint, from union and labor, what real change can look like for us to hear the announcement about $1.1 billion being dedicated to a hospital. That was not fought by just one group or one individual or one institution. It really takes collective action. And that's essentially the message. And so if you tune out, you got my message for today. This is going to take collective action. It's going to be cross-cutting, and it's going to have to be bold. I have nothing to report or disclose at this time, and you have some of my, well, you may, I don't know if it's in the booklet, but I have shared my purpose and objectives here, gaining a deeper understanding of the systemic challenges for health and healthcare delivery, discovering actionable strategies to advance equity in your organization, and being really clear that we're not just talking about health. If we are going to see the type of change, we're going to have to make these changes in all of the sectors that intersect with not only health, but education, and housing, and transportation, and that is the work. And so as we move forward in thinking about how we curate these conversations and the spaces that we're sitting in, we need to make sure that the person that is sitting next to you doesn't just have the MD or the RN or the LPN, but we're also thinking about the cultural strategist, the content creator, and the educator, all the different people who are in the communities that we are talking about today. And so I will not belabor the point in going through all of the objectives as I was just rambling. I'm sure that many of you were reading. And so in my brief agenda, I'm just going to be unpacking, as I mentioned, some of the context of the inequities that we're seeing here in New York City. And so for those who are not really versed with New York City, and as you heard from Dr. McDonald-Pinkett, it is different here, and it's certainly different here. But I think that there are threads that we must pull on to make sure that we understand that we're all a part of this human connection, and we're facing similar challenges. How do we build capacity for action? How do we then think about what reimagining health looks like? And I'm going to try to do all of that in now the 5 minutes I have left. So the way I'm going to sort of talk about this context, I'm going to just talk to you about some of the work that was happening in 2021. I'm not going to go back to 2020, as many people will remember in 2020, the fight to really raise the consciousness around what we were always talking about when we were talking about structural racism and health equity and health inequities. And really, because of the murder of George Floyd, it put the inequities that we saw, not only in COVID-19, but really the reckoning with racism in this country front and center. And so as a result of this racial reckoning, the New York City Health Department passed a resolution in October of 2021. In that resolution, we not only declared racism as a public health crisis, but we also outlined 9 commitments that the health department would undertake to advance its anti-racism work in New York City. This was a really seminal legislation piece of work that was passed to ensure that not only the health department would be able to do its work, but that it would be able to work across agencies, transportation and education, corrections and others, police department, to really use data in a really intentional way to think about how we were using funding, as well as how we can advance and push forward policy to continue to advance our anti-racism work. But what was really important, and if you have a chance to look at this this resolution, was really some of the language that we made sure to include in this resolution. One, we wanted to make sure that folks understood that what we were talking about, and we were super clear that we were talking about structural racism. We weren't just talking about interpersonal racism or institutionalized racism. We were talking about structural racism. And the reason why structural racism becomes really important, I want to make that distinction that often institutional racism is the focus, or interpersonal racism is the focus of papers and articles, and oftentimes it is also the focus of organizational strategies. But when we're talking about structural racism, we're talking about the societal, the ideological frameworks that are used, those systems and practices that are shared, not only by your institution, but other institutions as well. That's what I contend, and what others, I would say, contend is the work that we must do. By naming structural racism, we are naming that it is not just our institution that is perpetuating these biases and these discriminations. There are multiple factors at play. And here in New York City, we have seen how these policies have come to fruition. As you can see in the upper left-hand corner, transit, expressways and crossways moving in and pushing through Black and brown communities. And we have seen, as a result of those decisions and those policies, the outcomes for not only health, but also economic deprivation, also community development deprivation as well. And then even also moving into housing, moving into criminal justice. And so you get the point of how these policies can really perpetuate discrimination and bias in communities, and not just any communities. We're talking about Black and brown communities. We're talking about indigenous communities and other people of color. And that is what I think we have to be clear about. And we're talking about structural racism, that these practices show up not only within healthcare, that they also show up in other sectors as well. And so we wanted to make sure that in our resolution that we name that structural racism is the issue, is the original sin that we are focused on, and that these 9 commitments were really outlined and designed in a way that this wasn't the work of the health department alone. And so as we're sort of thinking about how we can not only impact and advance health equity globally, I think it's for us to sort of think about what the internal work of organizations look like, acknowledging the harm, repairing some of the work that we've already done, and then moving past our 4 walls to think about how we are doing cross-cutting work and how we're connecting with different institutions and sectors to bring about change within the community that we serve. And so that, I think, is the call to action for many of us. And so as a result of these policies that we have seen in transportation, and I'm sure other speakers will talk about how redlining has also led to the impact of what we're seeing in these maps here. And so as a result of what structural racism has done, we're looking at many of these, the impact, and not only in health, but we're also looking at it from life expectancy and the outcomes that we care most. Many of you all care most about, whether it is here in New York City or the communities that you serve in as well. Whether you are in south side of Chicago or you are in Southeast DC, you can overlay the maps of your communities, and you may find many of the same patterns, I'm sure of it. And so as we look at these three maps that are in front of you, from left to right, making sure that we sort of see where Black and brown communities are most concentrated across New York City, whether you're looking at East and Central Brooklyn, where you are right now, or you're looking at the South Bronx, or you're looking at Northern Manhattan, or parts of Staten Island, parts of Queens as well, where the higher concentrations of Black, Indigenous, and people of color are in New York City. You also see the patterns of life expectancy or lower life expectancy. You also see the patterns of higher preterm births. Now, if I was also to look at jail incarceration rate or higher non-fatal assault hospitalizations due to violent injuries, or we were looking at cardiovascular disease, chronic disease outcomes, cancer outcomes, what do you think that those patterns will all look like when we're talking about the worst rates? Would they align with these maps that you're already seeing in front of you? Oh, come on now. I know it's early. I know it's early. And I tried to make sure the volume in the microphone is working. But I think that you all are with me and are following with me, that the information and the patterns will certainly track with other outcomes, whether we're thinking about social or environmental or other health outcomes. And so using data to really make sure that we're showing the injustices is the work of ensuring that we're doing our anti-racism work. This isn't always easy to be able to uplift it, and then also think about what those actionable strategies are, right? And so it is a huge step for government to be able to own some of its own failings. By one, not even saying that we have disaggregated the data in a way that we're intentional in showing where we have neglected and disinvested in our resources, and also we have perpetuated discrimination and bias in those same communities. It is really important that government takes that step, because I think it would also role model for other organizations, both in the private sector as well as the public, to ensure that they are also following suit as well. Where are your resources going? How are you engaging with partners? How are you ensuring that your resources are really prioritizing, not just targeting, prioritizing the most neglected, those who are most marginalized, those voices who we keep saying that we want to uplift? Are we actually connecting with them? Are we actually engaging them in the way that they will be benefiting from our services? And so understanding how structural racism plays out, not only in our own practice, but also in the practices of the institutions and the organizations that we work with, and then being able to reflect that in the information that we are sharing. Because data is going to help us understand whether what we're saying and whether we're putting our money where our mouth is. So here, just to get a little bit more hyper-local, I know that we are not in Brownsville, but we are in East Flatbush. But we, right now, as we're thinking about our service area for our institution, there are approximately 1.25 million people who live in our catchment area. East Flatbush is certainly one of them, stretching all the way to Canarsie, Midwood, coming back to Brownsville in East New York, Bedford-Stuyvesant, Crown Heights, For those who are familiar with the borough of Brooklyn or the planet of Brooklyn, those neighborhoods sound familiar. For those who do not, let me just say it another way. You think about where Biggie or Jay-Z lived, or you think about where Little Caribbean or Little Haiti might be. These are the neighborhoods that we are very much focused on. And so when we're looking at the data, we see similar outcomes when it relates to premature mortality, as I just shared with you, preterm birth rates. And so when we're thinking about life expectancy and premature mortality, one, we also understand that there is a bit of bias even in the data that we're looking at, because oftentimes, and we also struggled with this when I was at the health department, the reference population is not always the reference population that you want to use, meaning that we want to make sure that we're not just looking at the white population as our reference population. As you see in the previous slide, we're even naming a non-white population as reference for you to understand how we began to disaggregate the data instead of thinking about Black and Indigenous and people of color. And so understanding even some of the limitations in our data, but it still helps us in really understanding where we need to prioritize our resources. And certainly Brownsville, when we're thinking about some of the demographics of the population, when we're thinking about the social and economic conditions of a neighborhood like Brownsville that has less than 100,000 residents who live within a 2 zip code area. But why do we see some of the worst rates in this one area? And those are the questions that we often try to wrestle with and really try to think about how we can direct our services, and then who do we partner with? Who do we engage with? Who do we ensure that those individuals understand what resources are available to them, but how do we disseminate it in the way that folks can really participate and trust in those resources and understand that it is for them? And so the problem, I would say, that we're trying to solve is not trying to make sure that all of you understand what the vision is. It's really making sure that we can build the trust to able to execute the vision. That's the problem. And oftentimes we create the documents, and there are more documents that are being created, and healthcare institutions have an opportunity to really be able to repair the trust, the damage that has been done, the mistrust that has been placed within the communities because of the lack of work that we have done in the past. There's a lot of work that we must do to repair trust from Black and brown communities, for them to ensure that they see these institutions as their institutions, as they are being more civically engaged in the management and the decision-making and the outcomes of what these institutions are going to look like. And so again, I reference this process that over a year and a half, where the University Hospital of Downstate, the future of it is at stake. This room was filled to the brim. Folks were engaged in the planning and the discussion and wanting to see that the vitality of this institution was not going, the status quo was not going to remain, but something better was going to emerge. And now we have that next step. But what does the next step look like? And that is what I contend is most important. In 2016, there was also a process for the hospital and the health system that I worked at, where community and labor, clergy, policymakers came together to come out with a vision that really talked about improving the clinical quality outcomes for the system, ensuring that the population health needs were going to be met, to ensure that an institution and a system was going to be charged with also the economic vitality of the communities that it served. All of those words sound great. But what is at stake is really making sure that community sees itself not just as the recipients of those services, but really as part of the design and the execution and the implementation of what the vision is going to be. And that is part of the work that I've been helping to lead at One Brooklyn Health, ensuring that we're bringing community closer to this institution that sees itself as an anchor institution, strategically partnering with organizations as we design new interventions that align closely with the system's priorities, but also to really think about what is our role in also being an economic engine for this community as well. If we are not meeting the social needs of our community, then it is really hard for those who are delivering the clinical care that is much needed. As you've heard, cardiovascular disease, cancer continues to be the leading causes of morbidity and mortality for our communities. And so if we are going to make headways and really addressing those outcomes, it is going to be important for us to also think about all the other outcomes that are most important to our communities as well. And so in 2016, as I talked about sort of this formation of a new system that focused on clinical quality outcomes, that also focused on population health needs, that also focused on revitalizing the economic well-being of the community. Also at the bedrock of it was also this advancing a health equity strategy within the system. And so a lot of that was led and started within our clinical quality team, really beginning to outline different projects around cardiovascular outcomes, around social determinants of health, and being able to not only identify but address those social determinants of health. And I'll talk a little bit about our Food is Medicine project. But then also beginning to look at health literacy as well. And so there were a few projects that the clinical quality team began to focus on, working with departments across the system. And what we have seen is that this was also sort of an engagement in the education process for leaders across the system as well. And I think that that's really what we learned through this entire engagement is how much there was a variability about what people knew about what health equity even meant, and what the role of system leaders and department heads, what their role were in really making sure that they were participating in advancing that strategy as well. And so as we began to retool in 2021, we began to really think about, well, what is our responsibility to both educate not only our patients, but educate our staff and our leaders to ensure what their role is, and to really think about what that engagement process was going to look like across the system. So we designed town halls, we designed surveys, we designed trainings to not only for our department leaders, but also for our residents, to really begin to have conversations around advancing health equity as a system, and really being able to get granular in the work within the departments of how you design a health equity improvement project to meet the type of quality targets that we need to see, particularly for the populations that are most marginalized. And that has really allowed us to fully understand what type of tools need to be designed for certain care models, for us to think about innovation as well in our clinical care models, and to think about who we need to strategically partner with as well to really enhance the type of care models that we need for our patients. And I think those are the steps, and I think those are also going to be some of the themes that you'll be hearing throughout the day as well. So as you saw in the previous slide, as we began to really design our own ways of addressing social determinants of health across the system, we have since standardized the way that we screen all of our patients across the system around addressing social determinants of health. And one of the social risk issues that continued to come up for us was food insecurity. And our former CEO gave me the task to begin to design a lifestyle medicine program for our system. And really the goal was to improve the way that we were not only thinking about the well-being of our patients, but also for our staff as well. And so we began to partner with organizations such as Grow NYC, Cultivating Justice, Isabel Ladies of Elegance, to really think about how we can not only address food insecurity, but also strengthen our local food systems within our communities as well. And another way of thinking about that is that we have growers and aggregators right here in Brooklyn. We have farms that are within a 100-mile radius of our health system. And how are we partnering with those growers and aggregators to bring food and ensure that the community understands how those food systems can really improve their own well-being? And we're not needing to go so far away or to source food from other states, but really thinking about what's in our own backyard. And so there were a number of different things that we took on, educating our staff about lifestyle medicine and food as medicine through a training with the American College of Lifestyle Medicine, starting a community-supported agriculture food box program for staff and also patients as well. We subsidize the food box for our patients, increasing access, particularly for our ambulatory care patients, which was referred from our ambulatory care providers. But then also working with local growers in Brooklyn, in Central and East Brooklyn, to make sure that we were sourcing and then also educating and doing nutrition education for our community members as well. And so we are continuing this program in 2025. We're now expanding the program, working with a local grower right here in Brooklyn who has multiple farms in East New York, as well as in Brownsville, sourcing food from Brooklyn, but also from New Jersey and Pennsylvania. And now we have 2 providers who are going to be looking to start their own lifestyle medicine practice as a pilot. And so these are the conversations that really started with what we're seeing in our data and moving to, well, let's then pilot a food box program that will really allow us to think about how we are engaging our patients and addressing a specific issue that we're seeing in our diet, and then having a different conversation with our providers. Another major issue that we continue to see in our data, and particularly in East and Central Brooklyn, is community violence. I know workplace violence is also an important issue as well, and so I don't want to minimize, but I think when we're thinking about community violence, I think there are many forms of violence that we want to address. And certainly community violence, when we look at our non-fatal hospitalization rate, we have the second highest rate of non-fatal hospital assault due to violence coming into our emergency room. Kings County, which is just around the corner, across the street, also has a high volume as well. And so in 2023, we retooled and rebranded our hospital-based violence intervention program by bringing in our local cure violence partners or crisis management systems. Depending on where you are in this world, these could be violence interrupters, these could be credible messengers, but they go by many names, or community health workers, to ensure that we were doing 3 things. 1, we were providing crisis management in the time of troubling need for someone who was coming in with a violent injury. 2, we were providing wraparound services for individuals as they were being discharged. And then we were partnering with individuals to really think about the root causes of community violence so that we can really stem the tide of this revolving door of violence that we're seeing in our community. And so now we are moving into the 3rd year of this retooling that we're doing for our program. Last year, we saw over 3,000 cases. Those are not unique cases. We have about a 10 to 15% re-injury rate among the populations that are showing up in our ED. And so there is an opportunity to not only address the community violence that is coming into our ED, but also to reduce the re-injury rate among those who are presenting. And we are seeing intersections, obviously, of domestic violence, of substance abuse, of homelessness among the patients who are showing up. And it really requires us to be strategic about the type of partnerships that we have to ensure that we're addressing what is presenting in our emergency department. And so we're currently being funded. Grateful to say that in this most recent budget approval by the state, that there will be additional dollars to hospitals to really expand their hospital-based violence intervention program. And as we think about sustainability, we are also looking at ways that we can use Medicaid reimbursement as well to sustain the program. And that was actually passed in 2024 in New York State to through the state plan amendment to allow hospitals to use Medicaid dollars to also fund their hospital-based violence intervention program. Here are just a smattering of other examples and the ways in which we are trying to work in advance and build capacity towards action in advancing health equity. And just to name a few, I know my time is short, really thinking about how we're utilizing patient voices to drive transformation, to drive change. We're really looking at ways that we can use patient experience surveys through a partnership with Narrative Nation, really to support mothers who are, or pregnant persons who are birthing at our institution, but also a patient experience survey that was designed in collaboration with this esteemed institution, as well as Arthur Ashe Institute for Urban Health. And so using the Brooklyn Health Equity Index, we are now using that information from patient surveys to then think about how our quality improvement projects can be enhanced as well. And so we were the first institution to actually roll out this survey. There is now ongoing work to now expand this to other institutions, including University Hospital at Downstate, to name just one other. We have since launched a community advisory board, thinking about meaningful engagement with our community partners. And also what I'm really excited about is a new initiative where we're using art in a way to tell stories, to really uplift voices of our community, to really begin to design transformation and bring those voices into our system as well. And then lastly, what I'll just say as I started is it's really going to take collective action for us to reimagine health in this next chapter. And health isn't really just thinking about the outcomes, that our own individual outcomes that we may have, but really to think about our well-being, our vitality of what our community is going to look like. It's going to really think about the type of data that we're going to need to be able to tell the stories, but to make sure that we are unearthing the uncomfortableness of what we know to be true in our communities. It's going to be thinking about the different tools, yes, in our care models, but the tools that we will need to ensure that folks will remain at the table and also can be very, engaged and also to be in a way that folks can fully immerse themselves in that process. And oftentimes those tools do not allow, if they're very academic and oriented, if they are very healthcare oriented, it does not allow or disallows other groups to be fully engaged in that process. It's going to think about different ways that we can use communication. Yes, social media is really important, but also thinking about ways that we are coming back into spaces where folks can feel like they are getting updates and there's transparency and there are opportunities for folks to also lift up their displeasure with the process. There is an opportunity for institutions, whether you are an academic institution or hospital, or whether you are a banking institution, to see yourself as the backbone support to really help drive the change. This will require resources that we know that the federal government is trying to take away. And so to be intentional in how this work does not go away is to think about what resources can you share, whether that is going to be an actuary role, or if you're thinking about someone who is going to be data mining, or whether you're thinking about a researcher, someone who can be contributive in the way that can help sustain the planning, the coordination, and oftentimes just to make sure that we are putting notes together and so folks are getting updates. And also, ultimately, it's the agenda, right? It's making sure that we're really clear about where we want to go. And designing this vision for health and wellness requires us to be bold and be courageous in this next moment. And so I thank you all for your time and for your attention, and I will cede the floor to Dr. Pepper.
Good morning, everyone. And, it's an honor to be here and invited to be a speaker at the 8th Annual World Health CME. Okay, need to be over here? Oh, I could talk loud now. Okay. Okay. So, just 1 second. So my presentation will be on patient engagement and cultural competence, a roadmap to achieving health equity. So just the slides. Yeah. Yeah, that's what I was doing. Yeah, okay. So I have no financial disclosure. And so my presentation, let's look at it from what's the purpose and the objective. So the purpose is to present strategies to enhance empathy, respect for cultural beliefs, and equitable care delivery, with a particular focus on improving the outcomes for individuals with sickle cell disease and the elderly Black population. And the objective is to increase empathy, respect and understand individuals' cultural beliefs regarding their health, prevent judgmental behavior directed at patients, prevent disparate care, maintain patient dignity, and improve the health outcomes for a diverse patient population with a focus on the elderly Black population. So in terms of the agenda, we're going to talk about the overview of the session, the purpose and the objective. We're going to explore cultural beliefs and attitudes, examine the role of language in medical documentation, discuss the significance of the why question in patient care and the perception reality, share strategies to enhance cultural competence among healthcare professionals to better provide responsive and respectful care. And going to do a case study at a patient at Kings County and to summarize key takeaways and then question and answer and closing remarks and the CME credit questions. So who are we? Who am I? And, you know, so I don't know if I need to go over all this, but I'm an accomplished physician for over 20 years. I pioneered the key initiatives at New York City Health and Hospitals, such as care management program focused on sickle cell disease, and the first sickle cell support group I started, and drove significant reductions in congestive heart failure, readmission at Kings County Hospital. I developed patient engagement and cultural competence training program that has been widely accepted at Khalida Health, Northwell, Toro Medical College, and recently at Morehouse Medical College as well. I'm a fellow of the New York Academy of Medicine, and I received Excellence in Medicine Award from the Bronx County Medical Society in 2021. And I presented at prominent meetings and published several peer-reviewed articles. My book, 9 Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients, was published on June 19, 2024. And by the way, it was my birthday. And it's #1 bestseller in the new release category on Amazon and #4 in health. So we're going to identify our cultural beliefs and attitudes. So what do we as individuals in this room value? We value self, family, work, integrity, religious, cultural, and ethnicity, finance, health, fun and recreation, privacy, dignity and respect, and choices. And you'll see choices is in red, and I'll explain that shortly. So are patients really different than ourselves? I would assume the patients value the same things we value, including choices. So when the negative language in the medical records, I'm going to address in a moment. So when you say choices, so let me ask the question, what is the similarity between a homeless person and a millionaire? Does anybody could think of a similarity? Huh? Could be. So when I do presentations, most of the time the answer I get, well, only thing I could think about is that they're both men. I said, there could be women too, but that's another story. So what is the common thread? Once accurately diagnosed, there's no human being on planet Earth can give it back. The millionaire can't say, I'll give you $1 million to take the cancer back. Oh, that's not enough, I'll give you $5 million. In life, we have choices, and this is the only time that there's a non-negotiable that serves and recognizes all human beings, irrespective of race, gender, ethnicity, social economic status, country of origin. And so maybe health systems could be more empathetic and less judgmental, and to recognize the bulk of us taking care of patients never laid in a hospital bed. And those that do are women delivering life, and in some cases, patients may be trying to prevent death. And so with that background, when you look at now negativity in the medical record, how many times have you heard the word non-compliant? Raise your hands. Oh, and there's a nicer word, non-adherent. Yeah. How many times have you heard the associated why question? So isn't that kind of interesting? So we don't know why John Brown didn't take the medication, but we're going to refill the same prescription he didn't take and don't ask why. And then if he doesn't follow directions, you're going to have non-compliant, non-adherent. You know, if it's written in the medical records 2 or 3 times, that patient is under the help bus. Who's going to care about that person? Because everything is his or her fault. In other words, frequent flyer, no longer human. Anybody know who came up with that term, frequent flyer? High utilizer, game in the system, and deserving of punishment. Drug seekers, oh my God, for patients with sickle cell, how many times have you heard that? Okay? And it's an unfair characterization of patients with sickle cell disease. And when you have these negative language terms, it creates a culture of callous disregard and possibly contributes to poor health outcomes. So counterproductive thought process. Documentations, as I mentioned, rarely mentions the why. Physicians and nurses, we are trained to ask why, right? God forbid we don't ask why the fever, why the headache, why the abdominal pain, why? But when it comes to asking the patient, why didn't you do something? So I'll give you an example of this particular true story when I was at Kings County in charge of the congestive heart failure readmission prevention. 60-year-old African-American male recently diagnosed with congestive heart failure, returns 2 weeks later, congestive heart failure decompensated due to non-compliance. So when that person goes up to the unit, you think anybody's going to care about that person? I don't care what hospital. And one of the nurses down the hall says, so he just got diagnosed with a life-threatening condition and don't follow directions. I got other things to do. My team had to ask why. Why? Because they said, if you don't ask why, they used to call me Dr. B. Dr. B is going to bug out, you know. So I asked, why didn't you take your medication? And I'm glad you're all sitting down. Why can't you take your medication? I can't take the water pill. Why can't you take the water pill? Because I drive the number 7 train. So when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores, I take some of my medication, but if I'm going on my shift, I don't take the water pill. The same cardiologist who was ignoring him, I brought him in, and that's why I think systems could change. He said, take the water pill when you get home. Be aware it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle so you could use in a private space when the train stops. And you know what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing, you know. And I said, expand the conversation. You know, he would have been readmitted multiple times, right? And then they would have called him frequent flyer. And then if he were, and you know he was going to die. There's no question about it. And at mortality, it would have said died due to noncompliance. It was died due to noncompliance if we didn't ask the why question. And it would have been our fault as opposed to the patient's fault. We were able to save this black man's life so he didn't have to choose between his health, his job, and his life. So the negative language can cause potential adverse health outcomes, cause repetitive emergency room visits, cause increased readmissions, and increase the health burden on patients. So patient responds if you ask the why. If you are a hospital, and I give instructions to patients as well, if you're in the hospital on a doctor's appointment and you are asked, did you take your medication or did you follow direction? The patient responds, no. Wait a few minutes. If you are not asked the why question, say, do you want to know why I didn't do it? And please don't write non-compliant and non-adherent in my medical records because it can have a negative impact on my health outcome. Could you imagine if patients are now communicating that information to physicians for change in culture? So, eradicating misperception and fallacies, perception versus reality. Because if your perception of me is not my reality, my health is going to go south. But if the perception and reality is the same, good, bad, happy, or sad, we have an opportunity to collaborate with everyone. Perception, reality versus reality. So the COVID pandemic had shed bright light on longstanding numerous health inequities experienced by Black Americans across the U.S. The Black population had the highest COVID death rates. Perception, the prevailing thought that it was a result of poverty, lack of access to care, social determinants of health, and comorbidity. The reality actually is that Prince George County, in Maryland, right outside of D.C., one of the wealthiest Black upper-class communities in the nation, and they had the highest COVID mortality. Brooklyn, New York, has a significant Black population, is home to at least 13 hospitals, including 3 public hospitals, 1 state hospital, extensive public transportation, and they had the highest COVID-19 death rates in New York City. It was in Brooklyn. The public transportation employees who died were predominantly Black, who were union workers with an average salary of approximately $50,000, and they had pensions and they had health coverage. And probably the reason why the bulk of the patients, the bulk of the employees died, because at that time we were just learning about COVID. And the bulk of the people that I work on the subway system and train transportation are Black. You know, so we have to put things in the reality of the situation. It's all contributory. So let's look at the myth of patients with sickle cell. Sickle cells have a higher degree of drug addiction than the general population. The fact is, opioid addiction for sickle cell patients ranges from 0.5 to 8% versus 3.0 to 16% in patients with other chronic pain syndrome. And I created the first sickle cell support group, and these are just some of the statements from patients. Could you imagine when a patient who is about in his 18 or 19, I have a 50% chance when I'm admitted to a hospital, someone will be nice to me. This is from the patient's own words. And the pain is like a sledgehammer, constantly hitting me up and down my spine. When I'm in crisis, the pain is so severe that I really want to die. When I'm at home and feeling better, these thoughts go away. Yes, I'm a drug seeker. I need drugs to relieve my pain, but I'm not just seeking drugs, okay? And this is a population, their voices and the humanity and who they are as human beings is not discussed. And to recognize the fact that the bulk of patients that with sickle cell and the families, there's no family counseling offered. I really did research on family counseling. When one child has sickle cell and one does not, how does a family cope with it? And there's no family counseling. But these services are offered to patients with cystic fibrosis. And what is the difference? Okay? So the treatment of sickle cell patients, individuals diagnosed with sickle cell, they receive, as I mentioned, a low standard of care. Race does play a role. And the social construct of race in America requires the majority of patients with sickle cell not only to face the consequences of serious health condition, but also to navigate a society in which the color of their skin is often at an unfair disadvantage, which causes them to be labeled drug seeker. And it's been proven in the medical literature, patients come back to the emergency room earlier than, quote, they should. It's not because they were seeking drugs. Guess what the main reason was? They were undertreated the first go-round, okay? And the medical evidence does not support, as I mentioned, the term drug seeker. So the questions and comments of patients that are in the emergency room, and I think I would want to share that with patients. I'm a human being who happens to be African American. I have a life-threatening disorder, sickle cell disease. I'm in severe pain and I need to be valued and treated now. Like you, I have dreams and aspirations, so please do not cut my life short because you don't think you value me. And if there's no response, ask to speak to the ED director. If you didn't have a PCP and you were admitted or you're going to be discharged, ask that you get a hematology consult, because a lot of times they're not offered hematology consult. And so could you imagine a patient and a family member is telling, I'm a human being. Why do I have to now become a human being in order for you to treat me? And I'm sure you have heard the word sickle cell warriors, and everybody think it's cool. That's what patients now of sickle, they're warriors. They have to be warriors. So I'm 21 years old or 18, and I'm potentially midway through my life expectancy, and I have to be a warrior. What does it tell you? If I have cystic fibrosis, I don't have to be a cystic fibrosis warrior. If I have leukemia, I don't have to be a warrior. So what is it about being a patient with sickle cell? What does it tell you about a health system when I have to be a warrior and I'm potentially midway through my life expectancy? And so, as I mentioned, ask for behavioral health services and to be able to discuss your fears, anxiety, depression, family, circumstances. Make sure you have a follow-up appointment if you're being discharged. Don't have to feel uncomfortable in requesting mental health counseling, and it should be a vital part of your treatment for sickle cell disease. It should be offered. Patients shouldn't even have to ask for it. We should ask, I want to recommend you to see a therapist or a family member, a family counseling. That should be offered. And recognize the need, as I mentioned before, life-threatening cystic fibrosis, they don't have to do that. Okay, so this is an important statement from Dr. Zemsky, who's a pain specialist in Connecticut. He said, in the words, difficult patients are not just born, they are in part created by their passage through the medical system. Not only the system failed to cure, it may have done unpleasant things to make matters worse. Sorry. Oh, what did I do here? I'm sorry. I'm sorry. I'm not really good at this. Could you come and help me do this? I don't know what I did. I apologize. My kids have given up on me and my computer skills. Yeah. Just go back to keep going, where I came from. Yeah, go, so. Okay, yes, from Dr., I'm sorry about that, my apologies. And so I tell patients to keep that statement from Dr. Zemke in their phone. And so when they go to the emergency room, show that and say, please don't do unpleasant things to make my condition worse. Thank you. Could you imagine a 21-year-old patient now, black patient, male or female, is now showing medical literature to their doctors in the emergency room? So let's look at cultural competence. Cultural competence is defined as the ability of providers and organizations to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. A culturally competent healthcare system can help improve health outcomes and quality of care and can contribute to the elimination of racial and ethnic health disparities. At Kings County, it was a very humbling and amazing experience. And my team they did such a great job. And the population, 93% of the population were of African ancestry, 50% of the patients were Caribbean, 36% African Americans, and 4% Hispanic. The patients of non-African ancestry were 3% white and 4% other. And so I was in charge of the congestive heart failure readmission prevention program from 2011 to 2014. And what we realized is that the daily questions that the team had to ask: who is the individual? What are the fear factors? That's another thing that's not covered in healthcare, patient fears. Could you imagine how you could see how patient fears can potentially lead to non-compliance? Okay. What's important to the individual, not what we think should be important to the individual, but what is important to you, as opposed to me telling you what should be important to you. And where is the person in the acceptance of the disease? Because if I'm planning a vacation for my family and I did a mammogram and it's positive, I may not even know who I am at that point. So this is where the humanity of it all, and for us to recognize the bulk of us taking care of patients never had any of these experiences. And the team philosophy, not to be judgmental, never use the word, as I mentioned, non-compliant without why, improve patient engagement and cultural competency, identify African American, Afro-Caribbean, and recognize the high patient value. And the reason I say recognize African American and African Caribbean, Afro-Caribbean, there was an Indian patient in the hospital, in the bed, and the nurse said, "Oh, where in India are you from?" And he got very upset. "I'm not from India. I'm Guyanese. I'm Caribbean," And so that's when I call the lookalike syndrome. And when I do presentations, I say, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Jamaican that they're Trinidadian. Go tell a Nigerian that they're Ghanaian. And tell a Puerto Rican that they're Mexico. And most important, listen to me carefully, people. Go tell a New Yorker they're from New Jersey. And that is not going to go over well. And to recognize and heighten patient value. So it's important because of the population, we need to understand where you're from. So the team was interdisciplinary. We had hospitalists, we had patients actually, if they could ambulate, could join the team. We had dietitian, pharmacy, care case managers, social workers. And we were able to decrease the readmission from 30% to 18.7 in less than 2 years. 30% decrease reported by the Kings County Medical Director, and 18.7 decrease. The report came from Medical and Professional Affairs of Central Office at Helton Hospital. And the person who came up with the 18.7 on the team, the clerical associate, was the least educated. And so when you understand, because I'm least educated, that doesn't mean I'm least intelligent. She kept all the data, and when the report came out and I said, "What's the number going to be?" And some people said, maybe 20%, maybe 21, 24. She said, no uncertain term. Dr. B, 18.7. And when the report came out, 18.7. And so when we think about education and intelligence, to recognize the bulk of corporate America, in charge of corporate America, are less educated than the people they hire. So patient voice. 84-year-old African-American female from South Carolina said, "My parents were a step away from slavery and my grandparents were slaves." 82-year-old African-American who stayed on a weekly day, "What I'm most concerned is that I will not be going to church on Sunday." She stopped eating. This was a Wednesday. Stopped taking care of herself, stopped participating. And everybody said, "We need to do depression screening, call psych." Absolutely, that's protocol. But I went in to see her and I said, "Could you tell me what's important to you?" And she said, "The fact that I will not be going to church on Sunday." I said, "Find out what church she goes to and let me speak to the minister." We found out I spoke to the minister. He came in and he prayed with her and told her, "Even if you are not discharged on Sunday, I will come back and pray with you." She was a different woman because she no longer felt guilty of not pleasing God. And to recognize the role of religion in the elderly black population. I don't think there are 3 black women or men across the world that are atheists in that age group. And I say, When a Holocaust survivor comes in the hospital, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see that patient, and so they should, because of the horrific circumstances that they endured. But when an elderly black person who fled the South because of Ku Klux Klan, lynching, and Jim Crow, and the atrocity happened here, how come we don't roll out the red carpet? And they have the worst health outcomes in all disease category. And it's an opportunity to recognize and treat all atrocity survivors the same, and to realize the role of religion in these two populations were pivotal to their survival. So who are our patients? Not only are they English-speaking and American-born, but they're also from different countries. They speak several languages and may have different religious beliefs. They may have different expectations regarding the healthcare needs and the role of healthcare providers, and they may have different beliefs about using Western medicine versus herbal medicine and or home remedies. Challenge: not to have the patient choose between health and family, health and culture, health and religious beliefs, health and finance, and health and education. Cultural sensitivity towards foreign-born patients. American clinicians need to understand cultural norms that are different from American norms. The role of, this includes the role of the caregiver. The caregiver may not be the decision maker in other countries, and the role of the clinician in other societies. Example, I say you do philosophy. So we have to understand, how do we understand the cultural norms and what's the expectation from the population we serve. Just in summary, behavioral health starts with healthcare professionals and executives. Professionals and patients share the same human concerns and emotion. Illness trumps religion, ethnicity, race, gender, and culture, and historical trauma can influence patient behavior. Terms such as frequent flyers, non-compliant, non-adherent, used in healthcare setting towards patients can create a culture of callous disregard. A culture of callous disregard can negatively impact patients' health and safety, and thus affect patient compliance. We can all become patients at any given point in time. And just an example, when I did a survey with doctors and nurses, and I said, how many people are taking medications? Everybody raised. How many people are taking 5, 4, 6? No, the top number was 3. There was one in front of me said, I'm taking 1. I said, oh, how often do you take it? It's 10 days. I said, I'm assuming you're taking an antibiotic? He said, yes. I said, are you compliant with it? He said, well, I'm on my shift. I got a lot of things to do. Sometimes I forget. I said, well, patients are on their shift too, and they're taking 5 or 6 medications. Sometimes they forget. But, like I said, it's busy, So I said, so you are non-compliant? And he said, you're right. I won't use that term anymore. So I said, how many more days do you have? 3. So you got 6 pills to take for 3 days. Please be compliant, I would assume. Okay, thank you. And so... So which of the following interventions we would like to simplest to implement in a clinical setting? Perception, reality, elimination of the word non-compliance, understanding the role of patient fears, and assessing whether the role of religion influences a patient's decision. Cultural competence should apply to all race groups, non-English and English-speaking, and English-speaking population, and one's gender. And to recognize cultural competence is the American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients. 35% of physicians in this country right now are foreign-born. And cultural competence for American-born physicians to American-born patients who are different than themselves. And we found that out at speaking to a lot of the patients. And the difference is, from my perspective, the patients were included in the solution. And I'm sorry, did I run out? I have time? 1 minute. So just one elderly black patient, and I thought, I was being really nice, and I said, where are you from? And I said, how can I help you? Can I help you? She said, you want to help me? Do something with yourself. Get me out of this bed. Laying in this bed makes me lazy, okay? So I said, oh, okay. Who takes care of you? I take care of myself. I do my own laundry and I do my own purpose. So these are the elderly. And the other patients, I said, where are you from? And I said, remember I said, ask, where are you from? Where are you from? South Carolina. And I'm thinking, when did you come to New York? Did you come to New York for family event and you got sick, or do you live here? And her statements was, yes, my parents were a step away from slavery and my grandparents were slaves. I said, and I had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And then I had to walk 10 miles to a segregated school. And I'm thinking, walk 10 miles? We can't even go 5 blocks without calling an Uber, you know? So I said, how did you walk for 10 miles? And her body language changed. And she said, well, if you want an education, you had to. Like, what part of this don't you get, stupid? That was the bottom. And I said, did you have to walk back? And she said, no, the principal in the horse-drawn carriage took us back. And we had to get back before dark, before the Ku Klux Klan. I said, how old were you? 10 years old. Could you imagine? 10 years old. And then she went on, continued to educate, went to Voorhees College. It's a 2-year black college in South Carolina. I had to look it up. And she came to New York in the 30s and 40s and continued her education and became a dietitian. Her how many people heard of Stuyvesant High School? Her 2 children were 2 of 5 black children to integrate Stuyvesant High School. And they're in our hospital beds and not in the history books. And please, if you're taking care of, quote, and I asked the patients, if you're taking care of an elderly black patient, there are certain things that you really should think about it. If she was your grandmother, how would you want your grandmother to be treated? And and somebody said, well, grandma don't listen to us, you know. But I said, if you're graduating in medical school and you come to a system that's toxic towards a particular population, black population, 6 months later, you're going to be toxic as well through no fault of your own. Systems have to change, and to change is the human value. And thank you.
Good morning. It feels like it's been a long day already. My name is Karen Roberts Turner, and I am from the Howard University, and I thank Dr. Shelley McDonald Pinkett for that very warm introduction. I have no relationships, financial or otherwise, that I need to disclose, so I will get right to it. My topic is ethical decision-making in diverse populations. We've heard quite a bit. Dr. Beverly, thank you for teeing up my presentation about healthcare inequity. In that inequitable model is a patient who often has limited choices, and the decisions that the patients make will obviously impact the health outcomes. So if we look at how to better equip patients to make decisions, we can also work towards achieving health equity in that manner. So the purpose of my presentation will be to examine how culture, religion, and societal values affect ethical decision-making among various patient groups, multicultural patient groups primarily. We will define ethical principles in healthcare, look at the SHARE framework for ethical decision-making, discuss influences on healthcare decisions, and then identify strategies for promoting culturally sensitive ethical practices and improving health equity in the process. What is ethical decision-making? I'm glad you asked, because I have a slide here to tell you. Ethical decision-making is just a cognitive process of deciding something, coming to making a choice. But when you ask about ethical decision-making, it encompasses the rules, the values, the beliefs, the principles, the guidelines that form our moral framework. And we rely on those to help us make our ethical decisions. There are 4 fundamental ethical principles, and if you ever have taken a healthcare ethics course, these may look familiar to you. These are not the only ethical principles that exist, but these are the 4 fundamental principles in healthcare ethics. Autonomy is self-determination, the right to self-governing, the respect for persons, beneficence, the intention to do good, to promote the best interests of the larger group, non-maleficence, not doing bad, above all, do no harm, justice, the commitment to fairness, equity, and commitment to following the law. When we talk about making healthcare decisions or making any decisions, these ethical principles are not the only reference that any of us might use. We will consider our cultural influences, our religious beliefs, even our political ideologies, and we cannot forget our societal values. Dr. Beverly introduced us to a concept called cultural competence, which, thank you, but it bears repeating that as actors within the healthcare community, it is our responsibility to understand and appreciate people from other cultures, our patients, our colleagues from other cultures, and not just with an acknowledgement saying that it exists, but with a desire to appreciate and interact with members of other cultures so that they feel that they are respected, that the relationship that is built between the provider and the patient or the colleagues is one of openness and respect and compassion. And it also requires some self-awareness. We have biases. I know I do. And if everybody's honest, you know you do too. We have our own biases that we bring into the relationship with a patient. You may see, and I use this with my students, a patient may come in with a hat that has those 4 letters that I'm not going to repeat, but you may have a reaction to that patient and say, oh, they support a particular political party. I feel a certain way about that. I don't want to treat them. You don't have that choice. Or you may be the patient and a provider comes in and you just know that they don't view your same culture, they're maybe from a different culture, and that creates a bias. So cultural competence, cultural humility helps as clinicians to acknowledge, accept, and to actually do the work to eliminate that from the relationship so that once you get into a situation where you have to present a patient with a treatment plan or a care plan and have a discussion about options to make a decision, it's a more open and respectful, less conflicted proposition. These are who patients are. They are gender differences, they are cultural differences, but when it comes to care, the care cannot be biased. So that's the background. Ethical decision-making. I like to refer to this model that was created by, or I should say formulated by the Agency for Healthcare Research and Quality, AHRQ. I'm from DC, so we use initials for everything. The SHARE model that is a clinician-led approach. It's a collaborative approach where patients and providers actually collaborate and together come to decisions that will guide the patient's care, but they are based on the patient's values and preferences. The SHARE is seeking your patient's participation, and by patient, that would include whoever the patient's decision maker is if it's not the patient, or whoever the patient wants to be involved in the decision. The H is help your patient explore the options and compare the options. Sometimes there is more than one approach to treating a condition, and there may be benefits to one that make it a better option than a different one. So helping the patient focus on those differences and what best aligns with that patient's Preferences is what the A is, assess your patient's values and preferences. R is help your patient reach a decision. Patients are the ultimate decision makers. Caregivers do not make decisions for patients. The most you do for decision making is in the offering of the options. You make some educated choice about what to offer the patient, and then it's out of your hands in terms of the ultimate decision. But you are required to help your patient reach that decision by assisting with the evaluation of the options, and then once your patient makes the decision, having a conversation. Okay, what does that decision now mean now that you've reached it? When you're in a patient care relationship where your patient or your provider, you have different cultural implications, these 5 factors can impact decision-making and the outcome of your patient's care. Communication, treatment preferences, perceptions of illness and pain, the role of others, and religion. These are just a few, just to illustrate the point of how cultural differences or diversity can impact decision-making. And to the extent that decision-making in this context, if it's based on moral beliefs, ethical principles, religious beliefs, it's ethical. It's your moral decision. Let's look at communication. And we had this conversation this morning in the car. Communication encompasses not just what you say, but how you say it. And I'm going to say, if anybody in here has a Black mother, you already know what I mean. That look, that look stops you in your tracks. Well, as healthcare providers, when information is given to patients, the facial expressions, the body language, the tone can vastly impact how that information is received and understood. So in certain cultures, it's not just non-English speaking versus English speaking. It's the way you say something, the way you approach a person. Dr. Beverly mentioned older women. If you're a younger person, you don't roll up on an older person. Hey, Shirley, I heard you're sick. Shirley's going to shut down, all the way down. You have to, Miss Johnson, what brings you here today? You have to understand that part of your patient's experience. Obviously, non-English speaking patients require assisted communication through interpreters, but you also have hearing impaired patients whose I don't want to call it a disability, but whose impairment may not immediately be visible, but you as the provider need to know if you have a hearing impaired patient, you need to take the extra step of making sure that there is someone who can communicate with that patient. Cultural nuances also can affect how information is received. Patients may use slang, cultural idioms, or local dialect that may not translate well into your understanding as a clinician. Likewise, you may use terms that patient doesn't understand. So making sure you're communicating on a level playing field has a serious impact on how the information will be received. And then also, just in terms of communicating, culturally, some people, some patients do not say a lot. They will not share a lot. They will not express pain, even if they are in pain. And Dr. Beverly references, and I'm actually going to mention this later under religion. There is I'm not going to preview it. I'll wait. So there are also patients who will say they don't want to know bad information. Just don't tell me. If it's bad, don't tell me. As a clinician, you're obviously conflicted. You kind of have to give the patient information, but the patient has the right, because they have autonomy, to refuse information, to refuse treatment. So you have work to do to try to figure out how do you achieve your responsibilities as the healthcare provider to make your risk manager and your lawyer happy that you have fully advised your patient of their condition and their options and all of that. But at the same time, respecting your patient's choice not to be told. And if it's culturally or religiously motivated, then you certainly have a little more work to do to try to figure out how to resolve that. Involving others, reaching out if you have a multicultural affairs office in your institution, or even the caregivers or family members, respecting HIPAA without releasing any PHI, but having some way of communicating with the people around the patient for some support or guidance on how you might be able to get through to your patient to be able to better communicate. Your patient's selection of treatments may be impacted by their religion or culture. I'm sure we've all heard that Jehovah's Witnesses will refuse blood transfusions based on their interpretation of biblical texts that command abstention from blood. If your patient is refusing blood and you ask why, this may be the reason. And this doesn't mean that now you don't treat the patient. It means you now find alternatives for accomplishing the same goal while respecting the patient's refusal of blood. Similarly, patients may be guided by culture or religion or even societal beliefs in refusing to be vaccinated. In that situation, you likewise find some alternative if it's available. If it's not, you document. Any patient refusal, whatever the reason, and it's better to have a reason for why the patient refused, documented, and that will enable subsequent providers to understand what happened during your course of treatment and not view this as a case where either you didn't do what you were supposed to do or that this patient is not compliant or just not a cooperative patient in this process. The perception of illness is often shaped by culture or religion. As referenced earlier, a patient may not share that they are in as much pain as they are in because they may believe that that pain is a punishment for sin, it's a test of faith, or it's just part of God's plan. I have to go through this, and so I'm going to go through it. I'm not going to let you fix it, Doc, because I need to go through this. This is a spiritual journey for me right now. Okay, that's that patient's choice. But understanding and respecting that is what, as the provider, you just will have to release if that is what your patient's choice is. And then really, another challenge is the patient who does not express how much pain they are actually in. There are other signs. I'm not a doctor. I have played one on TV before, but there are other signs of pain. You will get tachycardia, right? And there may be other things that happen. So your patient is just sitting there. No, I'm fine. But you see things going up and down. You address that. Okay, I hear you. You say you're fine, but I see these changes. And so let's try to address that. And maybe in that way, you can connect with your patient's pain and address that. Because even if the patient wants to have the pain, you as the physician know that may not be a good thing. You may still need to fix whatever is causing that pain. And so you may have to do a little respectful work to get to the point where you can get to the source of whatever's causing that pain and have the patient be willing to accept what you offer. Now, I certainly could not talk about pain and pain perception without addressing the reality that in this American healthcare system, the misperception still exists that Black people can endure more pain than is reality. So that sickle cell patient who comes in, not only is he or she viewed as a drug seeker, frequent flyer, but half the time, oh, I don't believe your pain is that bad. It can't be that bad. Or you can take it, you can handle it. So non-Black physicians, and let me not even say that all Black physicians understand this, but any physician who has some bias when it comes to pain perception of any other population really does need to do some work, because diminishing or minimizing your patient's expression of any symptom, especially pain, is a sure way to have that patient's care be woefully inadequate and continue to perpetuate the inequities that we see in some of these populations. How other people are brought into the healthcare decision-making dynamic is often driven by culture or society. In American culture, we are a personal choice, independence, it's my choice, it's my decision society. But that's not the case in other cultures. So if you're a clinician thinking that your patient is going to make all of these decisions, and so that's who you're focusing on, and the patient is deferring to someone else, you have to be prepared to incorporate that someone else into the conversations, because if the patient is deciding that they are willing to have other people or another person make their healthcare decisions, then that is their choice. Again, the patient is still autonomous, even though they're, excuse me, passing or sharing the decision elsewhere. So striking the balance between that autonomy and the collective decision-making is that's your job. That's what you have to do, because ultimately the goal is to achieve the outcome that best serves the patient's interests, even if that decision is not made by the patient. Religion and spirituality have direct impacts on decisions. A Catholic patient may refuse to be a living donor for a sibling, even though, why wouldn't you want to give your kidney to your sister? She will die without it. But their religious belief is that she can't, because organs are not supposed to be removed until somebody is actually dead. So it's not that she doesn't want to, so she shouldn't be judged for not agreeing. She should be respected, and the conversation should be gentle and more compassionate, and maybe what other options do we have? Similarly, a female Muslim patient may not want to talk about her urologic or GYN issues with a male doctor. It's not that she doesn't want to talk, it's just talking about something that's sensitive with a man. You recognize that, oh, okay, well, I will bring in a female physician or a nurse or somebody that you can communicate openly with. And other faith traditions may have certain requirements for how end of life or life support and tube feedings are conducted. So if you have a person of the Jewish faith, they may need to consult with a rabbi first about tube feedings and end of life care. Well, you give them the space to do that without, oh, we have to make this decision right now. No, you don't have time to do that. If that's what their faith or their culture requires, then you extend the courtesy of allowing that to happen. Sometimes, like with the autopsy, the refusal may not be just, oh, I don't want an autopsy. It may be that their faith or their culture prohibits autopsies. And if that is the case, no matter how important you as the clinician or the researcher may want that you have to respect that person's faith. And feel free to document that this patient declined an autopsy because, but don't make it sound like they did something wrong by saying no. And certain end-of-life care, many people of faith would want to have a faith leader, a pastor, a rabbi, someone at the end of life. And so to give the patient and the patient's family the courtesy of being able to do that will certainly make the family, that process of losing a loved one go more peacefully. So how do we get to a framework where we are able to have patients feel like they are able to express themselves and make ethical decisions in situations where either they or their providers are of different cultures? One of the first ways is to learn that about your patient. If you have a relationship with the patient as a primary care, it's a little easier, but if you're just encountering a patient in a hospital setting, you still have the opportunity to understand and get to know and involve family members or caregivers to help you understand the do's and don'ts. Having that information will be very helpful as you guide yourself in that course, and also as you develop your treatment plan. Integrating any type of recommendation or health initiative that the patient suggests. If it's possible to incorporate that into your care plan, that's one way that you are showing that you're recognizing that they have a certain faith tradition. For example, if the patient requires prayer at a certain time, well, you make it possible for that to happen. You don't, if you can, don't schedule a test at a time where you know the patient has already said they need to be praying. That will help. It may not help the condition, the medical condition, but it'll certainly help the emotional and mental and spiritual condition of your patient, which certainly can impact their ultimate health outcome. In general, having an educated and informed workforce, your staff, not just medical or clinical staff, but any staff that may encounter the patient. You know, your frontline staff are often the first impression that any patient will have of your institution. And if the respect begins there, then you'll probably have a much happier patient by the time you get into the examining room. Be okay with acknowledging that we don't know everything. We don't have all the answers. There may be traditions from other cultures that work. And if that is what this particular patient chooses and it doesn't conflict with your integrity as a professional integrity to let them do that, then find a way, if you can, to incorporate that or to allow for that in that patient's care plan. We have sort of at every hospital that I've been connected with, Multicultural Affairs Office. I think that a lot of them are limited to interpreters. Well, there's so much more to this process than just interpretation. Just the educating about other cultures and understanding health traditions of other cultures would be an addition that any multicultural affairs office or service could provide. And it will help all the staff when they encounter some of these issues and provide resources for how to navigate when confronted with them. But having staff, clinicians, nursing, unit clerks of varying backgrounds also makes it for an easier environment to navigate when you know, oh, this is someone who's from X, Y, and Z. Well, we have someone here who's from X, Y, and Z, so let's see if we can talk to that person or have that person come talk to this patient so we can come to a better understanding for how we will navigate this process. And that representation should not only be on the workforce side, but also on the research side, because we know that research is what dictates a lot of the medicine that we practice. I'll say we. But it dictates the understanding that we have of patient populations. And if that research is only based on white men from Ireland or Europe, it's not ever going to be applicable to us, and there will always be a disconnect. So making sure that we're advancing representation in clinical research studies, in the workforce, but also we have to make sure it's represented in these large language models that AI is now based on, because that will kick out some information that has absolutely no relevance to the patient population in Brownsville or in Prince George's County, Maryland, or in Washington, D.C. And so that will definitely require some major work to sort of to right that wrong. So just to conclude, and I don't think I put a concluding slide, diversity impacts decision-making in such areas as communication, the perception of illness and pain, in the selection of treatment options, in the role of others in the healthcare profession, and in the expression of religion. Promoting ethical decision-making among diverse patient groups has to be intentional and encompass understanding and interacting with patients of different cultures, engaging in learning, ongoing learning. It's not just one seminar and now you're an expert, an ongoing learning experience that includes self-reflection and acknowledgement of biases, and then a commitment to correcting whatever those biases might be. And doing that will create a more open and respectful relationship where patients, regardless of their background, culture, ethnicity, belief, gender, gender identity, gender expression, can collaborate with healthcare decision makers, healthcare providers, and decision makers to reach conclusions that are informed and that align with the patient's values. And in the end, that will improve health equity. Thank you.
Can you see me? So I think it's still morning. Yeah, good morning. Wow. Good morning. Good morning. There we go, there we go. So I want to first of all say thank you to everyone for being able to speak with this group. It is a tremendous pleasure and opportunity, but I will also remind you of what Dr. McDonald-Pinkett said in the introduction, which is that I tend to roll a little harder than some of the others, and it's intentional. And a lot of the presentations up until now have focused on patient or on our vantage point to patient. This one will not directly, but it will indirectly, because my intention is to talk about something that started with the very first presentation. The very first conversation, the very first announcement this morning was about $1.1 billion. And how many of us have heard or can complete the sentence, right? No money, no mission. No money, no mission. And so we are inextricably tied together between our ability to achieve mission, our ability to impact our patient populations in the way that we'd like, and quite frankly, our ability to advance our professional goals with an environment that is, in fact, about dollars. So while we're talking about dollars, let me say I don't have any conflicts. I don't have anything to disclose. And my objectives are to be very, very transparent, right? It's to discuss the cost to healthcare organizations and healthcare providers of medical malpractice, of unethical behaviors, and of adverse activity in the public domain. So Ms. Turner talked about, and I'm going to try to say this correctly, non-maleficence. Non-maleficence, see? We have, it's part of the construct of what we're doing professionally. While I was sitting there, I put Dr. Beverly's book in my cart to purchase because the concepts are just tremendous. So we're going to discuss the professional consequences of unethical behaviors and unethical provider behaviors. We're going to describe the impact of medical malpractice cases and nuclear verdicts, and we're going to identify the consequences to public perceptions of adverse provider conduct. In other words, we're here to talk about the cost of getting it wrong. So I have one of those things of there's nothing that says continuing medical education better than the fact that you're going to hear from lawyers back to back, right? Because we're inextricably linked. And the reality of our environment is, I worked clinically for several years as a nurse, and I worked in the transplant program for a while, but I worked on the organ procurement side. And so I remember walking onto clinical units and having the providers, right? Not the patients, but the providers in the unit go, oh, here comes the angel of death. What went wrong? Why are you here? What patient are you here about? And I went from that to being in the risk management environment where I got almost the same kind of a greeting, right? When you walk up and say, hi, Dr. such and such, or hi, nurse such and such, or hi, pharmacist such and such. I'm from risk management. I want to talk to you. They go, we don't want to talk to you. So nobody was happy to see me typically on a typical day, right? But that was okay because I understood, my mantra, what I taught my staff is to make it perfectly clear that the reason why they exist, the reason why risk managers and folks like us exist is to make certain that for everyone within our organization, that their worst day, potentially, would never be their last day, right? Or we will never achieve the mission. We will never get to where we want to go. And so we've got to work on this together. But the result of that was that going into COVID-19, we sort of had this approach. And so I was absolutely thrilled when I could walk into my organization and see banners up that say heroes work here, right? How awesome is this? And I'm going, they love us. They finally love us. But it didn't hold up. It didn't hold up. And what I learned from it is that every good story needs a villain. Every good story needs a villain. So what do I mean? Okay. Are these familiar to any of you? These are social media, public domain impressions of healthcare and healthcare providers. So the Retrievals is about Yale New Haven, right? About their fertility. And that was a podcast and it was a series. Dr. Death, right? Podcast went viral. Everybody was listening to it and watching it. And Taking Care of Maya. Is anybody familiar with Taking Care of Maya? Taking Care of Maya, right? Is about the treatment of a young lady a young patient in a hospital in Florida affiliated with Johns Hopkins University, and what happened to her, and in particular what happened to her mother, right? Because there was this concern, right, about Munchausen by proxy and other things around the care and treatment of this little girl, and ultimately the mother, as a result of the actions taken by the hospital, the allegation is that the mother actually committed suicide based on the allegations around her involvement with the care and treatment of her daughter. So these are all public domain, right? People are consuming this information about healthcare and about healthcare providers. The question is, do we contribute to our own perception of being villains? Are we contributing to our own villainization? And there are lots of possible answers to that question. But what I know is that folks will say, in some ways we do. And the reason why they say that is based on things like what you see in front of you now, right? So the opioid epidemic, who got blamed for that? It was, oh, the doctors are prescribing all of these opioids, the pharmaceutical companies are pushing out all these pills, and the doctors are passing it through, and now we've got pill mills where people can come in and just pick up a prescription, and we're contributing to it. We're contributing to it in terms of what people perceive as the cost of their healthcare and who gets rich and who's making money off of healthcare at any given moment in time. We're contributing to it. Some would say, again, we're forcing each other to be in these horrible situations that we had this tremendous perception during COVID. And then what we found on the other side of COVID is that we had burned out clinicians, we had burned out providers, they didn't want to be in healthcare anymore. Folks were walking away saying, I can't do this anymore, I'm done, right? And so then you see this burnout and you see all of these things. But we also get this from the patient perspective where folks are saddled with what's the number one leading cause of bankruptcy in America? Medical debt, right? And so people are being told that their financial ruin is based on the healthcare system and how the healthcare system works. They're being told that we're at fault for that, right? That their pocket, my deductible and my copay has gone up. I've never had it go down. Have you? So the out-of-pocket expenses associated with healthcare, just another example of folks believing that healthcare and healthcare providers are actually taking from them in a literal sense, in terms of dollars and cents that healthcare is taking from them. And then you add to that fact that we are seeing certain healthcare organizations, not all, but certain healthcare organizations are reporting what? Record profits. To the billion, with a B, billion-dollar level. And we're seeing healthcare executives, the leaders of healthcare systems with salaries and compensations that mirror that of professional athletes, right? That you've got a $35 million annual compensation package, and it's for a healthcare or a health plan CEO. And so people are not necessarily believing that healthcare is suffering or healthcare providers is suffering or the challenges of healthcare organizations. So to move forward in the story, behind every villain lies a broken heart. What do I mean? This breaks my heart. What's your overall impression of doctors? This is from a jury research firm. This is jury research work. So you think 79% positive, that's a very good thing. What broke my heart was that only 17% had a very positive view of doctors. Only 17%, and 4% were willing to report that they had a negative view. If you look at the adjacent slide, the thing that stood out for me about this slide is Ms. Turner used to tell me all the time, because she's a darn good lawyer and a really good trial attorney. And she used to tell me all the time about needing to take the jury on this story, right? We need to take them through our story. The problem is this. According to the jury research, do doctors care about their patients? 40% are neutral. 10% disagree. 2% strongly disagree. Only 39% agreed, and only 8% strongly agreed. So basically, you've got a 50-50 split between neutral and negative and positive. 50-50 split. Broke my heart. Try as they might, doctors cannot prevent bad outcomes from happening to patients. Another pretty much 50-50 split. 40% agree, but 34% neutral, 12% disagree. This is turning into a 50-50 split. Why? There's no room for mistakes when it comes to the practice of medicine.
Look at the split. 37% of people agree with that statement. 14% of the jury research pool strongly agreed with that statement. And this is a personal problem for me because I am so annoyed with TV medicine, right? They really do believe it's all supposed to be perfect. They really do believe the problem is supposed to be resolved within that 55 minutes of their time. Going back to my transplant days, it used to infuriate me that every time somebody came into the ER or into a healthcare situation and they needed a transplant, what would happen within the next 2 commercials? Somebody would show up in the condition necessary that they could provide that organ. The recipient shows up and needs it, and 2 minutes later in the story, a donor's in the same emergency department. TV medicine magic, but it just doesn't work that way. But what we've done is create a perception that we don't make mistakes, that there shouldn't be anything that goes wrong, and that it all should be fixed. So this is not a realistic environment. So what does that translate into? This is what jurors are saying. 76% believe that corporate executives lie and cover up. 76%. 71%, there should be no caps on jury awards. 45%, it's okay to ignore the judge's instructions. We just want to do what we want to do here. 30%, it takes billions with a B to send a message to corporations. There's a percentage that's not on the slide. This is about what people believe and perceive about corporations or about organizations. But the other percentage that's not on the slide is that 70% of providers are now providing care under the banner of a corporate parent or owner. So if they believe that about corporations and 70% of providers are part of corporations, whether they be for-profit or non, they're really saying they believe that about 70% of the organizations under which our providers are practicing. That's perception. So declining trust in corporate institutions, shifting in the demographics and attitudes, and the normalization of mega verdicts, the quote-unquote Netflix effect. And I'll tie this together in a second. But I am not, I always was taught, when you point the finger at someone else, that there are 4 fingers pointing back at you. So I don't blame anybody. I'm not gonna point fingers. I'm just gonna say that this research from TransRe, which is a major insurance carrier, says that what's driving this, there are 3 things that are in common: the plaintiff's bar, the plaintiff's bar, and the plaintiff's bar. You have a very strong, very powerful, very organized group of people who are making their living off of being able to perpetuate this reality or this pseudo-reality, as I like to say. So what are the consequences? What are the costs? When we get into litigation and when we get into defense and we get into accusations of medical malpractice or malfeasance or misconduct, we get into this world where the plaintiffs are using these tactics to absolutely strengthen their ability to come after organizations and to come after providers. So we're seeing changes in strategy that says, hey, we are going to go after these individuals. We've got a strategy that works. We're going to provide things in litigation that give juries the chance to be outraged and angry. And we're going to make sure that we make them angry enough that whatever number it takes to send you a message, they are willing to give you. And we in the earlier slide, we talked about the fact that number, for many people, they believe has to start with a B, that it takes $1 billion number to get there. So the consequences in terms of the cost, I want to talk about nuclear verdicts. Has anybody in here heard the term nuclear verdict before? So a nuclear verdict, right, initially was defined as any jury verdict of $10 million or more. And when the court system and when we were being impacted by COVID and this perception was that, healthcare organizations and we couldn't move cases through the courts, they dropped significantly.
But then they quickly rebounded. Coming out of COVID, by the third quarter of 2021, they had rebounded to near record highs. The jury verdicts, excluding the pandemic years, nuclear verdicts are actually on an upward trajectory. And this is, again, one of those percentages that made me sort of stand back. 19% of nuclear verdicts between 2013 and 2022 were mega nuclear verdicts of at least $100 million. These numbers are real. We talked about these things, $183 million for a malpractice settlement, $138 million over here for a different organization. These are impacting organizations, but these numbers are becoming mission threatening. That the size of these numbers are changing the way that organizations are having to deal with their finances and organize their money. And this is one of those things where, we talk about strategic partners all the time. For those of you who saw my information or see the logo on the slide, Aon is is an insurance brokerage firm. And so we are looking at, in the healthcare practice, as to who wants to insure hospitals, who wants to insure doctors, who wants to insure provider practice groups. And I'll just tell you that the green areas that you see on the slides coming down from 21, coming up here to 2023, the green areas are when insurance companies were making money on medical malpractice. As the slides move towards the red and the yellow, the insurance companies are not making money. And so what do you think an insurance company wants to do if they stop making money? They don't want to write that insurance anymore. They don't want to provide the coverage anymore. We can't make money off of this. Here's why they're not making money. And I don't pretend that it's as simple as this. And I don't want you to think about it from the perspective of the insurance company. I want you to think about it from the perspective of that $1.1 billion that's allocated to hospitals and health. Think about it from your ability to work in your specific practice area because you're getting insurance, and what that means when these amounts of money come out of the pool and into the hands of folks that are coming after healthcare providers and healthcare organizations. These are the 50 largest verdicts from 2016 to 2024. And remember, I told you that a nuclear verdict was 10 million or more. We don't even get close to 10 million before we get through the top 50. So on the top end of the slide, you see $535 million. You see $400+ million. Those are actual jury verdicts issued out in healthcare cases. So that's what we're fighting against in terms of how do we keep the money flowing where we want the money to be going and attacking the missions, because what do we all know to be true? And I just, I'm so impressed by everyone that's spoken here so far. I just want to be clear, right, that when we talk about there are cuts that have to be made and things that have to be changed, where do you think they look first? It's these marginalized community, these programs, as we are sitting here now in a country where the discussion, right, is about cutting what? Medicaid. Medicaid is where the discussion is. So we need to be clear that it's the programs that are designed to impact the most vulnerable among us that become the first, typically, in the conversation about what has to go away if we've got a bigger bill to pay on this side. So, for example, if you think about it, and I grew up, I grew up in Prince George's County. That moniker that people attach to Prince George's County is the one of the wealthiest black suburbs. Yeah, I didn't know about that. I didn't know about that. I didn't know. If there was money around, I didn't know it. But what I also knew is that the programs that meant the most to me, things like free after-school rec programs, right? Things like free music programs in the schools, right? My brother, who was absolutely fantastic at industrial arts and was in a program to become a certified mechanic, when the school system's budget got tight, guess which programs they cut? Right? And so when budgets get tight, certain programs get cut, and we all have a pretty good idea of where they start. And so these things come together in drivers of the professional liability markets, where we're seeing things like, because the environment has become so toxic, that people are burning out. They don't want to choose healthcare. And so now we're dealing with staff shortages, right? Or people say, I got to make a whole lot of money to balance this out, and so we're not going to choose primary care, right? As we see the need for over 300 primary care providers just in one jurisdictional location, right? That the demand is tremendous, but folks are like, but in order to offset the cost of all of this, I've got to make more money. Now we're talking about the burdens of the hyper specialization of healthcare, right? Where are the family physicians? Where are the primary care physicians? Where are the pediatricians? When everybody is basically saying, I can't make any money doing that, right? So we're all seeing that. We're seeing this happen in legacy issues around sexual misconduct, right? And our ability to respond when you see that folks know more about, what happened and the misconduct of a particular doctor and shows like Dr. Death than they do about the work that very good clinicians are doing every single day, because that's not getting media attention. But these cases are, and we can't deny our accountability, right? That we have to hold a certain level of integrity. It is not comfortable for us to think about talking about or presenting to or making a case for another clinician or another provider that may be doing something inappropriate, but the cost of not doing it is devastating our ability to provide care to anyone. So I won't labor on this slide. I'll just talk about the fact that, obviously there's social inflation, and we all understand that, but now we're in an environment of pure economic inflation that is driving up the cost of everything, but that includes jury verdicts. We have judicial and legislative changes. We have a volatile litigation environment where we're seeing plaintiffs' attorneys and others willing to, again, villainize providers in order to be able to optimize their recovery. And one of the things that happens, as I talked about, is that carriers do not want to be involved with this, and they're rethinking their level of engagement within healthcare and within the healthcare industry. And what do we know about an insurance company? If it's a high risk, then what do we expect? High premium, right? The cost is most assuredly going to go up the more we paint ourselves in the position of high risk. So I would argue we're not villains. I would argue that we're not the bad guys. I would argue that although we must do more work, and what you heard today about from every presenter before me about our ability to stand up, our ability to communicate well, our ability to be effective with our patients, but also our ability to be accountable amongst each other, right? That there's nothing that irritates me more than when I find out that we have had a problematic provider, and we do research into that circumstance, and folks around that provider say, yeah, we knew something wasn't right about her. We knew something wasn't right about her. Yeah, we knew. Yeah, that guy, yeah, we knew something strange was going on. And when you listen to the podcast, if you decide to do it, I'm not going to encourage you to, but when you listen to podcasts like Dr. Death, that's what outrages our population. When you look at the retrievals, that's what outraged the population, is that people were literally saying, we knew something was wrong with her. We knew something wasn't right, but nothing happened. We can't afford to do that, and we actually have an ethical obligation to address it. So we can't run from it. And that's something that we have to do. We have to tell our story among our organizations and among our peer groups and in our professional environments, that we are taking the steps, that we are operating with integrity, and that we are doing things that make it clear that whether it's cultural competency, respect for diversity, that our folks, when they engage with our organizations, when they engage with our providers, that they actually don't walk away feeling offended. Right? To Dr. Beverly's point, my husband is Guyanese, and he told one of his physician providers that he is Guyanese, and the provider's immediate response was, oh, what was it like growing up in Africa? And he said, I wouldn't know. I am from Guyana, which is in South America, and we identify as Caribbean, right? And the provider went, oh, well, what's that country then? What's the other one? And I said, I think you may be thinking of Ghana. And the provider said, oh, yeah, now that one's in Africa, right? And my husband said, we can leave whenever you're ready. This person is clueless. That was his perception. No matter how technically good that provider may have been, his perception is this person is clueless. So we've got to deal with this in every field, right? We've got to deal with this in the media. We got to deal with this in our legislatures. As we have folks that are saying we've got to allocate more funds to make our communities healthier, I'm also saying when you do that, make sure that you're also willing to have the conversation about tort reform and protecting our institutions and protecting our providers in litigation and in lawsuits, because we got to have people to do the work if the work is ever going to get done, right? So again, we have to tell our stories. We have to advocate for ourselves and for the standards that we maintain. I started off this presentation with 3 examples, right? From Yale New Haven, from Johns Hopkins, right? And others. I just want to finish it in full circle. The headlines that you see here, they're very, very positive. It reflects very, very good work. They're also from the exact same 3 organizations that I started with. How much media attention did the good work get versus the villainizing work? We have got to do a better job of telling our story, because the work that we do in these circumstances, in my opinion, define who we are as providers and as professional organizations. And these are the stories that are being undertold. In the same way certain populations are being undertreated, certain professional population stories are being undertold and undersold. And I think that healthcare providers are among those. That is my story, that's my purpose for being here, and my purpose for connecting the dots is to say, when you look at things from 500 million to 45 million, and you start talking about how we protect our communities, how we protect our populations, how we reach the underserved, how we stay diversified, and how we continue to maintain ground, I'm going to tell you that it takes money to move the needle, and I would rather that money be moving the needle for you in that way than us moving the needle for plaintiffs' attorneys that can celebrate a $500 million verdict. My sermon is officially over.
What a wonderful morning we've had. I thank you all for just excellent presentations and for your expertise. I know we're a little behind and we're going to get caught up, but as they take their seats, if there are questions from the audience, I'd appreciate your coming to the mic now. You can come to the mic. And if there are questions in the chat, I know that we'll get some assistance with those. Yes, sir, please.
Hi, good morning, everyone. My name is Chairman Arthur. I'm from Trinidad. I'm a public health lecturer here, actually. Okay, hearing me clearly?
Yes.
Yeah. Just a couple of quick questions to Dr. Easterling, and I believe Ms. McDonald might be relevant. As an advocate for healthcare models in the Caribbean, I think the universal healthcare model seems to be more appropriate. I'm looking at the US model, and I guess it's a more market-driven, insurance-based model. And I am seeing greater and greater inequities. So I'm looking at the sustainability of the model, and I was wondering, what are your thoughts on which model should I be an advocate for? The second question is to Dr. Beverly. I'm very concerned about the dismissive, often very time-restricted sort of interaction of patient-doctor consultation. And it seems to be maybe not efficient or triggers sometimes resistance from some people. I know people that I'm familiar with that kind of resist going to the doctor because they feel very dismissed. And the third point is something that I was very intrigued about with Ms. Turner, I believe. when you indicated about, I think, certain religions may not allow for certain types of procedures, for example, blood transfusion with the Jehovah's Witness and with vaccinations. But I'm curious as to minors and dependents. What is I know I'm from a British Commonwealth jurisdiction, so the legal system may be different, but how do you resolve parents or persons who are in charge of minors making a life-threatening decision for these type of medical interventions?
Thank
So I hope
you.
it was clear in my
Yes, thank you very much. And so the first question, Dr. Easterlin, if you'd like to address that, and then Ms. McDonald.
Okay, mic check. Yeah, thank you so much for your question. Unfortunately, I'm not going to have a satisfactory answer because I think part of it is going to have to, you're going to have to do some homework on your own and sort of figure out what's happening on the ground, right? And so it's hard for me to say which of the two models, if even those two models are the most appropriate. And so, part of my remarks was sort of thinking about what does it look like for us to foster that meaningful engagement, to really think about how you pose that question to the folks who are living through the experiences that you're trying to change and trying to transform. How can they be the answers to the questions that you have? And I think that's the process that we really have to get better at doing. We're not going to come up with the answers. I think we're going to help come up with some of the theories and sort of postulate about what the approach may look like. But that's only part of the solution. And so I would say that we're still trying to figure out what that process looks like. I think that we have come up with some of those levers. We're sort of looking at what those factors are. But at the heart of it is really making sure that the voices of those who are most marginalized and often are out of the conversations and not in the rooms to really drive change, how do you really center their voices and make sure that they are going to receive the benefit of what you're aiming to do? So again, not satisfactory, but it's really about that process. So
Thank you very much. Ms. McDonald.
Say briefly, and I completely concur with what's already been said. And I'll just say briefly, when you ask which system should you be advocating for, for me, it's really about understanding what's doable in the context of which you're trying to achieve it, right? And so we saw this debate happen in the U.S. in terms of the Affordable Care Act, and we saw the amount of pushback, and we saw what we ended up with was a compromise based on what was doable at the time. And so I think, we have to look at that in the context. The right thing to do, I think, is I'll go back to my mantra, right? What advances the needle? And I think that is so situationally specific that there's no blanket, you should advocate for this and not for that.
Thank you very much for your response. And Dr. Beverly, the time constraint comment. His question was regarding the time constraint that we have in seeing our patients.
I think, I think I'm have a different approach based on my experience with the readmission prevention and the readmission results from Kings County from 30% to 18.7 within 2 years. It's not like the population changed. And I think when people talk about social determinants of health, is it important? Yes. But it doesn't mean because I live in the projects, my blood pressure can't be controlled. But it gives hospitals a pass, as far as I'm concerned. And I trained at Harlem Hospital back in the day. So if social determinants of health was a problem, okay, but we were expected to deliver excellent health care, whether you were a drug addict or whether you were a churchgoer. And I think when it thinks about time, I think if we engage the patient in a more humane process, the time over the course shortens. It shortens, and people are less stressed out. But if you continue to think I'm a problem and there's a discussion back and forth, then, I don't have enough time to do this, and I don't have enough time. When we didn't take a lot of time with the patients that required an enormous amount of time, we just asked simple question, tell me what's important to you. Why didn't you do something? And we were able to solve those problems. Did it solve every problem? No. But I think what's important to you and what we do in medicine, and we take a lot of time telling patient, well, this should be important to you. So I don't know why you're not following direction. How is that not important to you? Before you do that, why don't you ask me what's important to me? And then now we have a different conversation that it resulted in less time and more results, you know. And just a point I wanted to make about East Trinidadian, I'm Ja, okay? Jamaican background. And what I found interesting, I just want to give this, there's a Haitian patient that was refusing, you know, the language line. And, you know, to be able to translate, she refused. And everybody said, well, what do you want us to do? She refused in the language line, how we're going to communicate. I said, well, why don't you ask her, if she doesn't want to do that, why don't you ask her who she trusted to translate for her? And one of the Haitian nurses on the team said, Dr. B, it's because of the Papa Doc syndrome. And I said, what? Mm-hmm. She did not trust the language line because she didn't trust anybody. And so the policies that we have in place, I said, well, find out who she trusts, and her daughter. And they said, well, you can't do that. I said, what do you mean I can't do that? I can't do that, so we're going to have her sit in the bed and don't talk to her because she doesn't want the language line. And these are things that takes unnecessary long time. Give her who she trusts. And we got her daughter, and he said, well, we're going to have to report this to patient safety or whatever. And off the record, I said, you go report to anybody you want, okay, but I'm not going to have this patient sit in the bed and not be cared for because she doesn't trust the language line. And I say that to say, the time that it took for all this didn't have to be, oh, you don't trust the language? Who's the best person to translate for you? Bring her daughter in.
Thank you, Dr. Beverly. And Ms. Turner, your question about the vaccinations in minors.
Yes, excuse me. The issue with minors is layered. You have a family or parent, a guardian who is the decision maker. Ideally, that decision maker should be acting with that minor's best interest. If the providers do not feel that is the case, generally the first line of approach would be to go to the hospital ethics committee to try to resolve the matter at that level. And if not, then the court is the ultimate arbiter of that decision. And courts can order that treatment be given against a parent's consent, against a parent's wish. So that would be how that would be ultimately resolved. But the hospital would have to initiate that process, since it's the hospital or the provider that wishes for that care to be given, and the parents are the ones that are refusing.
Thank you very much. Is there a question in the chat? Okay, we'll take one last question. Dr. Zenge, Howard University. Happy to see you here, sir.
Thank you, Dr. Pinkett. Thank you all for your presentation. Dr. Easterling, I was in a conference, a Howard Retreat conference about, I think last month, with the new connotation on DEI. When I was coming here and I said, we're going to be fighting health disparities and health inequities, what is the relationship between these words? I mean, if the federal government says no more DEIs, but we need to fight health disparities because they exist, and health inequities, what is your take on, if a grant is not needed, we can use the word? Because in that other place, they said the students, medical students who are publishing are trying to avoid using those words, but they exist. Can we stop using the words because what's the relationship between DEI, health disparities, and health inequities? If you're not going to be funded by the federal government, we need to fight what we need to fight.
Thank you.
Yeah, no, thank you for that question. I think it is something that we're always going to have to be addressing and having more discussion and dialogue about. I think the fight is not about the word, right? And I think you alluded to that point. The fight is really on how we ensure that the resources that are available, that could be either through the federal government or through some other means, are being leveraged for the work that we need to do, right, in our institutions. And so I think it's going to really be important that it's up to the organization to really think about how they're going to double down on this work. and I'm being clear about that we do need to figure out how we're going to double down on the approach while also still leveraging those resources. And so there are certain centers that are going to make decisions, certainly about how they're going to change some of the language and moving away from equity or inclusivity or diversity, but to ensure that those dollars are still being leveraged to do the work that it was doing, even when you were using words. And I think that approach makes sense in this moment, because we're gonna get past this moment, right? We saw that where there was sort of a proliferation of resources following the murder of George Floyd in 2020. We saw there were resolutions, there were fundings, there were centers that were named. And now we're sort of, going through this this bust cycle, similar to how public health, there's a boom and bust cycle for DEI work as well. We're gonna have to figure out how we sort of navigate this moment, and that's also sort of figuring out how we collectively work together. There are philanthropic organizations who are thinking about how they continue to fund these efforts. I know Robert Wood Johnson Foundation is using their Equity for Action grant cycle to also fund some of the research that folks were doing using federal dollars, whether it was the National Institute of Health, to make sure that that work continues. So I think that's ultimately what you're trying to get at, is like, what do we do at this moment? And it's essentially, and I was just telling my daughter this, figure out how we continue to move forward, right? In this moment, that's what we collectively have to do. That's our charge.
Thank you very much. Ms. Turner or Ms. McDonald, did you want to comment on that at all, or? Okay, that's fine. Excellent job. Thank you so much, everyone. We appreciate your questions and the commentary. Oh, I'm sorry. I didn't see you there, sir. I apologize. We'll take this last question, and then we'll take a 5-minute break.
Yes, good morning.
Good morning.
Yeah, my name is Dr. Michelle Jose Charles. So I think I have the opportunity to come and really talk here because I'm a health first provider. I'm a member of Medinova. I'm a friend of Howard University, and I'm Downstate alumni. Trained here. And I trained here doing everything internal medicine and GI. So I'm a specialist. So the thing is, I didn't want to stay and not to come to congratulate you guys. You did an excellent job this morning. It's a nice, wonderful kickoff, because every time I go to a conference or I have the opportunity to listen to those topics, it's really, really helped me. And until now, that still really helped me in my practice. With 40 years of practice in medicine, especially here in Brooklyn, capital of the world. So you have the opportunity to meet almost all those cases. So that's why I had to say thank you, guys. So you did an excellent job today. Thank you.
Thank you so much for your comment. Thank you. We'll take a 5-minute break. Thank you.